Hello, NephU community. My name is Jamini Patel, and I am a nephrology medical science liaison with Otska Pharmaceutical Development and Commercialization, Inc. Today, I'm joined by Dr. Edgar Lerma, who will be discussing the importance of hematuria as a biomarker in IgA nephropathy. Dr. Lerma earned his Doctor of Medicine from the University of Santo Tomas Faculty of Medicine and Surgery in Manila, Philippines, and completed residency training in internal medicine at the University of Illinois Chicago Mercy Hospital and Medical Center. He completed a fellowship in nephrology and hypertension at Northwestern Memorial Hospital, the Feinberg School of Medicine at Northwestern University, and the Veterans Administration Lakeside Medical Center in Chicago, Illinois. Dr. Lerma is a diplomat in the subspecialty of nephrology with the American Board of Internal Medicine and has authored more than 100 peer-reviewed publications and presentations. In recognition of his clinical work and expertise, Dr. Lerma has been elected to the Fellowship of the American Society of Nephrology and National Kidney Foundation, as well as various other nephrology and cardiovascular associations. In recognition of his teaching, Dr. Lerma received the Subspecialty Teaching Attending Physician of the Year Award and Physician Recognition Award for Excellence in Academics in 2006 and 2011, respectively, from UIC Advocate Christ Medical Center. At present, he holds the rank of Clinical Professor of Medicine within the section of nephrology at the University of Illinois at Chicago and serves as the Educational Coordinator for Nephrology with UIC Advocate Christ Medical Center. Dr. Lerma's research interests include CKD, hypertension, bone and mineral disorders, and dyslipidemias in CKD. Thank you so much for being here with us today, Dr. Lerma. We really appreciate your time.
It's my pleasure, Jamini.
Dr. Lerma, I'm really looking forward to talking about this kind of newish topic in IgA nephropathy, hematuria. And when we think about the presentation of IgA nephropathy, typically the first thing that comes to mind is proteinuria, but it seems that hematuria lately has become kind of an important part of the conversation. In your opinion, is hematuria a common sign in IgA nephropathy presentation?
Well, thank you very much for that question, Jaimini. So, whenever patients present to the clinic or in the hospital prior to being diagnosed with IgA nephropathy or IgAN, one of the common presentations is that of hematuria. Along with proteinuria. So, in fact, there's literature showing that microscopic hematuria is found in 70 to 100% of cases of patients with IgAN, particularly in children and young adults who present in the early phases of their clinical course. And then, it reminds me of this ASN board review course, which I attended many years ago, and Dr. Falk from University of North Carolina was giving a lecture on IgAN, and he mentioned that, when IgAN presents, there's so many phases by which it presents. So he entitled this "The Many Phases of IgA Nephropathy." So, for instance, the different patterns of clinical presentation include: one, it could be an episodic macroscopic hematuria or an AKI with gross hematuria. Two, it could be an asymptomatic microscopic hematuria along with proteinuria. Three, it could be a rapidly progressive glomerular nephritis, also with hematuria. Four, it could be that the patient presents with chronic kidney disease already. Or fifth, patients can come to the clinic and they already have nephrotic syndrome features. So it is important to realize that part of this diagnosis, by which that leads us down to the pathway wherein we do a biopsy and then diagnose IgAN, is the initial presentation with hematuria plus minus proteinuria.
No, that's definitely very revealing. And oftentimes I feel, in my conversations with nephrologists, sometimes patients present with hematuria, sometimes they don't, sometimes it's just macroscopic. And if you're seeing just macroscopic hematuria, you're not seeing hematuria in other patients, should nephrologists be actively checking for microscopic hematuria in those patients who maybe don't initially present with macroscopic hematuria?
Well, that's a great question. So, when we talk about hematuria, we always have to ask, how does one detect that anyway, right? So, remember that the initial detection of hematuria is usually by a dipstick analysis of a random urine specimen. So, dipstick tests are very sensitive for the detection of hemoglobin in the urine. And we say hemoglobin, this is the free or erythrocyte related factor with there are very few false negatives. And one exception, like patients who are taking large amounts of vitamin C, right? They can present with this. There's also some false positives, like in patients who have myoglobinuria or hemoglobinuria. So myoglobinuria, we see this in patients with rhabdomyolysis, wherein there's myoglobin in the urine and it makes the urine look red. So the dipstick will read that as blood. And then when we talk about macroscopic or gross hematuria, this is the one that imparts a reddish or brownish smoky appearance to the urine, depending on the urine pH. Now, couple of things that's important whenever you see this is that when we are talking about glomerulonephritis, like IgAN, and you see hematuria, like gross hematuria, there are usually no blood clots. So this is separate from when you see blood clots in the urine, right? Also, when we talk about hematuria in glomerular diseases, it is usually not accompanied by urinary tract symptoms. Because remember, one of the differential diagnoses of having hematuria is that of urinary tract infection. So GN with hematuria, they don't have urgency, frequency, or dysuria. Now, when one detects the positive dipstick test for blood, this has to be confirmed by a microscopic examination of the urine. It should be centrifuge, and then it should be investigated under phase contrast microscopy or some bright field optics under low and high power magnification. And then there's also the staining of the sediment, which can help, determine, are you looking at cells, are you looking at formed elements, and of course, again, in patients with glomerular disease, like IgAN, the RBCs or the erythrocytes, they are commonly misshapen, meaning to say they are dysmorphic. Around, say, 50 to 80% of the cells are dysmorphic, and they can also be microcytic or small. Now, one of the sine qua non of glomerular disease or glomerulonephritis is the presence of red blood cell casts, or what we call, or the presence of acanthocytes, which means presence of acanthocytes greater than 5% of all the RBCs that you see. And usually when you see this, it indicates that there's an inflammation. There's inflammatory glomerular disease. So it should be noted that among the few RBCs that you see in a normally properly collected urine, all are of a dysmorphic type whenever you see glomerular diseases. And the reason why they become dysmorphic is because the blood cells pass through these inflamed blood vessels, and that destroys the structure of the red blood cell.
That's very interesting. I never really understood that. And I think that's definitely kind of revealing. It's not just necessarily the presence of hematuria that should indicate anything, but we really do need to take a deeper dive and examine what the hematuria is trying to tell us, right? Because it
Yes.
could entirely mean something different if it's not a dysmorphic appearance or there are, no casts. So I think that can help kind of maybe differentiate a diagnosis. Would you agree? In that situation or help, kind of identify inflammation.
I definitely agree with that. That's why it's important that when you see hematuria, it tells you a signal that there's something inflammatory going on in there. One of the knocks on the dipstick urinalysis, however, is that, so in clinical practice, when the urine sample is collected in a cup, usually it stays there for several hours before it's taken to the lab. So sometimes those RBC casts, which are there, tend to be, by the time you look under the microscope, they're already not there anymore.
Oh,
So sometimes you miss that. Yeah. When you're in training and you're looking at AKI patients and you actually do the urine microscopy right there and then, you are able to capture that moment where you might still see the RBC cast there right away. So again, and this is the reason why there's a lot of some consternation, like, are we really going to rely on hematuria or hemoglobinuria in that case? So there's some issue of specificity.
Yeah, and as you know, when I speak to nephrologists, there's kind of two camps. Those nephrologists who truly believe that hematuria is really an absolute indicator for inflammation, and we must be looking at it and kind of using it as an indicator for treatment response. And then there are those nephrologists who aren't quite convinced that we really need to be evaluating hematuria. What does the current data suggest about what hematuria might indicate and how we should be looking at it? I know there's not really a lot out there, and it's still kind of this area of research that folks are pursuing, but what is currently published about hematuria and IgA nephropathy?
One of the things that we know, at least from literature, is that the prognostic implications of the persistence and magnitude of hematuria, well, this has a very significant impact on long-term outcomes of glomerular disease. There was a study that was published in CKJ a couple of years ago. This was written by Dr. Ladanzan, Dr. Fernando Fervenza, and Dr. Copo. And they presented two similar patients, both with IgAN, both 45 years of age, both have the same degree of proteinuria, 1.5 grams per day. One patient has hematuria and hemoglobinuria. The other patient did not have hematuria or hemoglobinuria. Now, if you look at their MES scores, they're almost the same. So one had like M1EO S1T1CO, and the other one had M1E1S1T1C1. So the difference is really in the presence and endocapillary hypercellularity. So what did they find in this study? Well, they showed that patients who had hematuria had faster rate of progression of the disease. And so this brings the idea that hematuria likely implies the presence of active inflammation. And when there's inflammation, these are likely the patients who would require immunosuppressive therapy. On the other hand, remember, if you look at the different therapies of IgAN nowadays, there's other drugs wherein they're looking at the hemodynamics, and there's drugs that are looking at the inflammatory aspect, like steroids, budesonide, complement inhibitors. So those patients with hematuria, which likely imply faster progression or worse outcomes, probably are the ones who should get the immunosuppressive therapy. So this is what we know. And in fact, if you look at the 2021 KDIGO guidelines on IgAN, they did sort of recognize this, right? So there's like a couple of practice points that, they recommend: routines, evaluation of the urine sediment for RBC morphology or presence of RBC casts or acanthocytes. And they also had another practice point regarding monitoring of the hematuria, its magnitude and persistence, because they say in this practice point, it may have prognostic value in many forms of glomerular disease. And this is particularly applicable to IgAN. And the most important thing, they made it a research recommendation that further prospective studies of the impact of hematuria on prognosis for specific forms of GN and its therapeutic implications. So right now, that's why you're right. There are two camps, right? There's people who say, yeah, we should use hematuria. There are people who say, maybe we're not sure that it has value. But I think I tend to be on the side of Dr. Fervenza and his group, wherein I think when you see hematuria, it tells you that there's active inflammation there. And this is the patient whom you probably would warrant immunosuppressive therapy.
So, this kind of leads me to my next question. Really, should the presence of hematuria be a guide to providers to certain treatment regimens in IgA? And it kind of sounds like, it should. We still need a little bit more evidence to maybe parse that out a little bit more, but it should be cluing you into maybe a particular route of therapy, perhaps?
Yeah, look at RAS therapy, SGLT2 inhibitors. These are things that probably will not necessarily affect the inflammatory component of the disease, right? So maybe for patients with IgAN, that's a given. But who should be given the steroids? or budesonide or the complement inhibitors, that's when hematuria I think comes in. So this aspect of hematuria as a biomarker of progression, for example, in IgAN, is really nowadays receiving a lot of attention. And I think there's even another study that was published a couple of years ago by a Chinese group. They did a retrospective single center study. And again, in these patients, they had like over 600 patients with IgAN with persistent hematuria. They divided the patients into high degree hematuria versus low degree hematuria. And in those patients with high degree hematuria, there was faster progression of renal decline or in GFR. And these were also correlated with histopathologic findings like the presence of crescents. So, I think there's something to it. It's just that, and even KDIGO did not dismiss it as not important. It's just that I think there has to be some more attention in looking at these aspects of the disease.
Yeah. No, I definitely agree. I think it's probably I feel like over the next probably year or two, probably going to be one of the most researched aspects of IgA nephropathy. And I think it's an exciting time to be hopefully looking for a biomarker. I know, that's kind of another hot topic in IgA nephropathy in an entirely different conversation. But, something as simple as, looking at hematuria in a UA could be, provide a lot of information for how we end up managing these patients. So yeah, looking forward to seeing what research is done and what the data shows. But in the meantime, Dr. Lorma, thank you so much for that informative discussion on hematuria and IgA nephropathy. We always appreciate your expertise and time. And thank you so much to our nephew community for listening in. And to stay up to date on our upcoming events, please visit nephew.org/events and follow us on our Twitter page at Nephew Community. Dr. Lerma, thank you once more. We really appreciate your time.
Thank you.